just want to start out by highlighting the issue unusual. So even when if we take the individual patient and ask the question whether that patient is at risk of getting, let's say, pancreatitis or thrombosis or severe neurotoxicity, for each of these toxicities that may be severe, the risk may be relatively low, but combined, it is more than 50% of our patients that will experience whatever serious toxicities. Let's say going into an intensive care unit and being on a mechanical ventilation, or having pancreatitis, or having osteonecrosis. So even though we may call these toxicities unusual, it's very much a subjective issue. So from a scientific point of view, they are unusual in the way we need to collect data from a lot of clinical collaborative research groups in order to collect sufficient patient numbers. And such activities are, of course, ongoing in the pondylolinear toxicity working group. So this is for the adult participants today, that when we do that in pediatrics, we have decided to join forces across the globe: Australia, Singapore, Japan, of course, Europe and the US. So collecting, you could say, 1,000 cases of osteonecrosis or 15,000 cases of neurotoxicity. I'm not aware of similar activities in the adult world. I know the German recent study on late effects and toxicities in adults. And I can mention that the activity that we have initiated on trying to collect host genome variants in 15 to 1,000 children with leukemia. The German adult leukemia group recently decided to join that effort to, both of all, identify issues that is of relevance to adolescents and adults, but also independently to see whether the risk profiles that we can identify in host genome variants can be replicated in adult settings. But that's really a need to collect that kind of data. So the first issue is really, when we talk about unusual, what is really unusual? If a patient is affected by a very serious toxicity, the parents don't really mind whether it's a pancreatitis or osteonecrosis. It's simply just bad. So we may need to have a more global view on these issues. The second thing is the whole question about how should we define and capture these. And we had this Lancet paper survey some years back, I think it was in 16 or 17, and there were no two groups in pediatric oncology that defined these toxicities the same way, or even address them in the same way in the protocol. And that's another issue. If we really want to compare data, we need some kind of uniformity. And that's in a direction we are also moving, talking about what is really severe toxicity-free survival. And I would like to emphasize, because I don't want to take credit for anything I don't deserve, that André was really one of the first people to highlight the necessity to integrate toxicities in our outcome evaluation. But we've moved quite far in recent years to try to move that forward. So that's my first comment, that each may be relatively unusual, but in combination, they are quite frequent. The second issue is that there's really two aspects about this. The first aspect is, what are the long-term consequences? And we are faced currently with a dilemma. Our science ethics committees and our national health boards, they require us to register toxicities as they occur. I mean, within 48 or 72 hours, and then nothing happens. So we may know the frequency of a specific toxicity acute as it occurs, but there's no requirement of systematic follow-up of what is the ultimate outcome. So for instance, if a patient had paresis during therapy because of thrombosis or long-lasting seizures, we don't really know what is the ultimate follow-up result of that specific patient. And I think that's the major setback. And that's why it's not just a question of complying to the requirement of the competent authorities who are only semi-competent, but also to, among us, have decisions both in pediatrics and adults on how should we evaluate the long-term outcomes. So that's my second major point. This is really what we needed. And that leads to the third major item, and that is, when should we re-expose? So the fact that a very large proportion of our patients experience these toxicities, and there are probably almost no patient that goes through the protocol as it is written in the main protocol, because they have treatment delays for toxicities, and we may have different attitudes towards how soon can you start after a severe neutropenic episode, or should the fungal infection has gone completely away, should it just be controlled before you restart? And when it comes to the organ toxicities, liver toxicities, seizures, various kind of other neurotoxicities, thrombosis, pancreatitis, it's very often left to individual clinician. So it's determined at sometimes tumor boards in the specific center, sometimes on a national level, but there's no consensus on when to re-expose or not. And this is always a major issue when we talk about toxicities at conferences, not least if we join forces with adult hematologists. And I think these are the three major needs. I think we should stop talking about unusual toxicities. And I put aside infections here. That's a specific issue, but for toxicities in general, we want to address each of those as long as they are serious, because if we combine them, they're quite frequent overall. Secondly, what are the true long-term outcomes of these toxicities? And only now data is emerging. Just to mention one example, if you have pancreatitis acutely, many patients will have chronic pancreatitis, but it seems to disappear after 8 years. So a very slow resolution process, and that emphasizes that we need a long-term follow-up. And thirdly, we need much, much better guidelines on when to re-expose or not. And for some of these toxicities, we have quite good case series or studies that support when re-exposure is reasonable. And the reason it's an issue is because we know truncation of therapy, whereas truncation of maintenance therapy, whereas truncation of asparaginase, it increases the risk of relapse. So that is my introductory statements, and let's open the discussion. Oliver?
Kjeld, can I ask a question?
Sure,
Sorry,
John.
Oliver. So it's great to hear about the expansion of your efforts to the adult groups, and I wonder how you're dealing with standardization of data registration and collecting to make sure that the analyses are the highest quality.
Yeah, so I mean, this is a very sensitive issue to collect DNA from patients, and it's much more time consuming. And that's why most publications only include the phenotype data. So what we're doing in the ELEGANT study is that we, across the 3 European consortia, so altogether IRBFM and ALEC, and that is 33 countries, we have decided to collect DNA once patients are in remission, and that will create a, you could say, host genome variant repository. And then clinicians, based on what we are already doing in the pondylitis toxicity working group, they can collect the phenotype data, which as far as it's been going, and I think we've been addressing 7 or 8 toxicities and collecting hundreds and hundreds of cases, that phenotype study will be done independently. So what the ELEGANT study then adds is that you can certainly put this extra layer of host genome variants to understand the phenotypes. And you don't need to do the effort yourself. I mean, it's taken quite a few years to get the data or the strategy approved across the consortia, and also to get the material transfer agreement in place across all of these countries. That is being successful, and many countries are now routinely collecting the host DNA send them to the data repository. It's then genome mapped, and then as groups decide on addressing a specific phenotype, either in their own leukemia consortia or across these 3 consortia, then we can subsequently add the genomic layer. And I can mention, Charles, that when we discussed it with the St. Jude researchers, with Japan, these groups say that they will be happy to validate findings as we've done previously, but there are certain, as you know, restrictions in sending DNA across the world. So it's been easier to do it within Europe or within these 3 consortia. But I could easily see that either we can confirm results that emerges from COG, St. Jude, Dana-Farber consortia, or the other way around. I mean, this is what we've done previously in some of the pondylitic toxicity studies, like, for instance, pancreatitis and host genome variants.
Okay, thanks.
It seems like a worthwhile endeavor, and I'm almost positively surprised that you already have success in the consortia that you managed, Kjeld. From my perspective, what you're looking at is not going to be only a long-term registry of from trial data, but actually what you probably need is prospectively planned real life or real world data just to get the sufficient power. And let alone in the UK, we've been looking at trying to access clinically annotated data across different trusts, and it's a nightmare. And so I'm really wondering how and the issues of consent, what different trusts and probably different countries demand consent. So you've been encouraging, but I'm still wondering how this could really work on a large scale in the communities that I've seen.
So first of all, I'm optimistic, but also a bit nervous. I mean, we have to see how this will pan out in real life. What we need to remember now is that most of the toxicities that is of interest to us is already part of the targeted toxicities in the protocols. So every protocol do register whether osteonecrosis or specific neurotoxicities or pancreatitis or thrombosis occur. So you don't need extra approval to address that kind of data. Secondly, for the elegant study, what is how we call it, but for that study where we collect DNA, it will require separate consent from the families, where they know 2 important issues. First, that the purpose of this collection is to link it to the phenotype data that is already being part of the targets in that study protocol. If we were to go beyond that, so say, for instance, that a group said, oh, we are already collecting asparaginase samples for activity analysis, couldn't we use those blood samples to study, let's say, endothelial function biomarkers? That would require a separate approval. But based on the fact that all these 3 consortium have a very wide range of toxicities that they have already decided to address, in addition, of course, to the leukemia genetics, so we can study germline, we can study the germline tumor continuum, things like CNS leukemia, things like MRD or relapses. You don't really add extra phenotypes. Now, our experience from the pondylitic toxicity studies that we've been performing is that most of the data is collected by clinicians going back and scrutinizing the data. And that is one of the reasons why the COG group, the US group, have not been participating, because they cannot go back to all the institutions and collect that data on an individual basis. But some of the centers have participated. Now, there will be some countries that say, well, we know that this patient had thrombosis from the registries, but we cannot go back and collect the phenotype data. Well, that will be collected for most of the patients, and then we can see whether the host genome variants linked to that, you could say, low-grade phenotyping fits and strengthens the finding that we had in the more granular data. So I think this is a process, and this is very much a starting point. We have done some studies already linking genotype data to the phenotype data on large international scale, and it demonstrates that it's not only feasible, but of course provides much more power. And if we at any time point is going to really link host genome variants to therapy, it don't work with the, you could say, the high impact single variants like TPMT or NOT-T15 or CEP72. We need to have much, much better polygenic risk scores, or even some kind of, I don't really know whether I like artificial intelligence, but you can do other more understandable strategies. But the only thing I can say, Oliver, is that it took a couple of years for the groups to approve the strategy, and there's been quite a high enthusiasm across the board.
Can I have a follow-up question on the genetic or the genomic information? I mean, obviously Charles here is has huge amounts. If I look at other centers, I mean the genotyping that is done is often limited still to a few genes known to be of relevance, and so probably automatically limit the amount of information that one can extract from them, because they only capture a kind of infinitesimal fraction of genetic information that is there and that might be relevant because it's not collected for reasons of costs and others.
So I didn't mention that. So that was my first comment. My second comment is that we very specifically say we're not going to explore for cancer-prone syndromes, because for ethical reason, of course, that is much, much more complicated. However, we recently, and when I say recently, it's within the last month or two, published our paper in Genomic Medicine on a strategy by which we can target and sequence 1,000 genes at a cost of €2 per patient. This cannot be used for common variants, but if you want to explore rare variants, which is of course the cancer-prone syndromes, that can be done at a very, very low cost. We're going to sequence now probably 300,000 Danish individuals for 500 to 1,000 genes that may have an impact of cancer risk, and some other rare variants, metabolic disorders, and so forth. Now, when it comes to mapping the tumor genomics, the acquired mutations, at least every group have that kind of DNA stored. And I won't say it's impossible, but it's very time consuming then to try to get access to host genome variants. So if, for instance, a group say, well, we can get the funding to go back and explore our tumor genomics because that's ethically more acceptable for a large cohort of patients retrospectively, well, then we can provide the additional layer of common variants rather than the cancer-prone syndromes to that specific project. So the implications of such a wide international collaboration is, I mean, the potential outcomes are quite vast. But you're quite right, Oliver. However, my guess would be if we move like 5-10 years ahead, the cost of whole genome sequencing and RNA sequencing, which basically provide nearly all the data that you need, will continue to drop. And it may even be that we don't really need the whole genome sequencing, because the targeted sequencing can be just as useful unless we do it for research. But if we want to do it to have a quite broad view on what are really the cancer genomics in those specific cases, we can do it at a lower cost that is available today. What is needed in that setting is really the consensus on the bioinformatic platforms, because the readouts may differ a lot, and Charles is a much better speaker on that issue. I just repeat what other people have convinced me, that you really need to get experience. I mean, there's numerous commercial bioinformatics tools out there, and each cytogenetic group needs really to be familiar with what the tools misses and what they can provide. But I think we are at a stage where this will develop quite rapidly in the coming 10 years. Sorry for taking up so much time.
No, thanks. That was really, really interesting.
Jack Bartram is the UK PI on the study. So that's one of the issues we've been discussing, because many countries now do whole genome sequencing. Can we extract that data? And of course, that's doable. So you could say we filled out the cancer-prone syndromes. And I mean, in principle, you can really filter out and just get the variants that fit a specific commercial SNP platform. But currently, the primary goal is really to collect the large data, and that will probably continue for a number of years before we really have the number power, before we link it to the phenotype data. Charles, do you want to comment? Or we lost him in midair?
Yes, I can. I mean, no, I'm here. Sorry, I'm on the move. Look, it's a super important issue, and probably we can't fully explore it today, but I guess we're just kind of breaking it out into areas, one of which is, I think, what you're not talking about, which is, the somatic sequencing and for diagnostics, and one is the kind of, research aggregation of germline data that enables the toxicity analyses. And there are a few thoughts coming through. I mean, the germline analysis for this is not really my area. It's obviously you and June and others doing this in the pediatric space. But with other efforts that we've been engaged in to aggregate data, there have been a couple of challenges, and they've been getting people to come to the table and upload their data and put it in one place, either through dealing with regulatory questions, so permission to move data around. Obviously, this is a big issue in Europe, as well as standardization of the data. And so again, I guess I'll put it back to you, Kjeld. I think it's fantastic you've got these groups to come and participate, but these are non-trivial issues, particularly if you're moving to large data sets with whole genome data, as well as associated phenotyping data. And I'd be curious to know how you're thinking about.
So really two comments, a political one and a scientific one. So for the scientific one, I mean, we already now have in Europe the Harmony platform, where many groups, including my group, have shared large quantities of data through a trusted party interface that makes it approvable by the regulatory system. It includes genomic data to the extent that they are quite limited, and we haven't really explored sufficiently whether that would be feasible when it comes to more extensive genomic data. There's really no reason why it shouldn't be the case, because in principle, when at least in most countries they interpret what is anonymization, it is stated that you shouldn't be able to refer the data back to a specific individual with use of reasonable means. So truly, if you have the patient's genome, you can know that those kind of data link to that person. So that's one part of the comment, that that may be one way to collect some kind of data. The other issues that I've been recently interacting with the European Parliament on how we address rare diseases. And of course, we are in the forefront when it comes to pediatric oncology, but for many of the others, you could say, 4,000 genetic rare diseases that affect perhaps 30 to 35 million inhabitants in Europe. There's no real good strategies for data sharing. And we were able, in collaboration with members of parliament in Europe, to convince the STOA committee, it's a committee under the parliament, to engage in this issue about how do we ensure prospective data sharing. So not linked to a specific project, but prospective data sharing across country borders. And it can even be within a single country. And there'll be a workshop in Brussels, I think it's June 28th, where I and Camillo Rosari, who's the current chair of SAIB Europe, and a few other people will present their views on this specific issue. So the hope is that the EU, because of the quantity, as I said, 30 to 35 million people in Europe have a rare disease, that they recognize that we need a specific means that allow this kind of data sharing. So I'm optimistic and skeptical that eventually the EU will try to solve that data sharing issue. How we're going to approach the issue transatlantically is, of course, much more complicated. But we are really letting the patients behind. And I can mention, just as a curiosity, that if we look back in the 60s, what did children die of? Only 10% died of cancer, children about 1 year of age. If we look at the issue today, it's 20% of children that dies after 1 year of age that die of cancer. So cancer become even more dominating today than it was in the 60s, because it's a rare disease and we have progressed much more rapidly for infections, certain inborn error of metabolism, of course, accidents, and a number of other items. So even though we are proud on how much we have a success in pediatric oncology, well, other pediatric entities have done even better. And I think that's something that the EU now on a political level recognizes, that we're really holding back the progress for rare diseases compared to the more common medical disorders. We'll see how it pans out. I know many people who are much more skeptical about the EU politics, but at least there are people in the parliament and in the commission that recognizes that we need to make changes in these areas.